Everyone. Today we are going to look at lung disorders referred to as obstructive lung diseases. And as the name suggests, obstructive, it means that there is obstruction to the airflow. From your anatomy and physiology, you know that the function of the lungs is to perform oxygen and carbon dioxide exchange. So if there is any abnormality in that exchange, then the effect is that you have accumulation of carbon dioxide within your system. Then if you remember the blood flow of the heart, where you receive blood from the body through the superior and inferior vena cava that enters your right atrium into the right ventricle. Then this is pumped to the lungs through the pulmonary artery. Then oxygen, carbon dioxide exchange occurs, and this blood comes back to the heart. Oxygenated blood to the left atrium, then to the left ventricle, and then it is then released to the rest of the body through the aorta. So whenever you have obstruction, it also affects how this blood flows to the lungs and how it flows back to the heart. And this can lead to accumulation of blood, or there being increased pressures in your pulmonary circulation to try and push blood into the lungs. And this causes what we call right-sided heart failure. So we're going to see that as a complication to the conditions that we are going to discuss today. So obstructive lung diseases usually encompass several disorders, particularly the four. We have asthma. I'm sure we've all heard of asthma, and there must be some of us who suffer from it. We have chronic bronchitis, we have emphysema, and then we have bronchiectasis, and we're going to look at each one of them individually. So these disorders are chronic, meaning that they're disorders that will affect your lungs for a prolonged period of time. Apart from bronchiectasis, these conditions are usually non-infectious, meaning that how they start has nothing to do with infection. And then these conditions are also diffuse. So you'll find that they affect both lungs and they affect multiple lobes of the lungs at the same time. So these disorders are also characterized by an increased resistance to airflow at any level from the trachea to the alveoli, and that's why we refer to them as obstructive lung diseases. Of these diseases, your chronic bronchitis and your emphysema usually can coexist together. So you can have one patient with both conditions. And this is seen particularly in smokers. And when you have this, they are usually referred to as chronic obstructive pulmonary disease, COPD. So when you hear COPD being thrown around, most of the time the clinicians is referring to a patient who most likely has chronic bronchitis and emphysema at the same time. So these conditions usually present with shortness of breath, and they also present with a productive cough, and we'll see how this arises. According to WHO, this chronic obstructive pulmonary disease, emphysema and chronic bronchitis, is the fourth leading cause of death worldwide. And nearly 90% of the deaths as a result of COPD occur in those under 70 years of age in low and middle income countries. Kenya is a low middle income country, and we are one of the countries that is affected by COPD. The only difference between developed countries and low and middle income countries is that tobacco smoking usually accounts for 70% of the COPD in high income countries. But for the low middle income countries like Kenya, tobacco smoking only contributes to about 30 to 40% of COPD, and majority of it will be caused by household air pollution. What do we mean? Because of poverty, people cook with firewood, people cook with charcoal, and burning these substances produces chemicals that will have the same effect as tobacco. So in our setup, because of that, we have many people suffering from COPD. So what makes a condition be called emphysema, another chronic bronchitis, another asthma and bronchiectasis? We're going to understand each one of them. But emphysema is usually morphologic, how the lungs appear when you take an X-ray or a CT scan will tell you whether this patient has emphysema, so based on appearance. Whereas chronic bronchitis is usually defined on the basis of clinical features. And we're going to see the definition of chronic bronchitis. So how the patient present, how does a cough present, how does a shortness of breath present. So chronic bronchitis is defined on the basis of clinical features, such as the presence of cough and recurrent cough with excessive mucus secretion, and we'll see the definition. For chronic bronchitis, it initially involves the large airways. We're talking about the bronchi and the large bronchi. Before now, they divide into your bronchioles and then eventually into your terminal bronchioles, where emphysema affects the acinus, the last anatomic site of the lung. So in severe cases of both, small airway disease, what we call chronic bronchiolitis, is usually characteristic. So it will affect the small airways. So although chronic bronchitis may exist without demonstrable emphysema, almost pure emphysema may occur, particularly in patients with inherited alpha-1 antitrypsin deficiency. So what does this mean? Each disease can exist on its own, but most of the time you find that there's a coexistence of both chronic bronchitis and emphysema, as I had stated earlier. But where you find emphysema alone with no chronic bronchitis, it is usually when the patient has the alpha-1 antitrypsin deficiency, patients who have cystic fibrosis. I'm sure you've heard of cystic fibrosis. As for asthma, it is usually distinguished from emphysema and chronic bronchitis by the presence of reversible bronchospasms. So for those who are asthmatic, they'll have periods where they wheeze, and then when they're put on medication, this wheezing goes away. So this is because of that reversible bronchospasm. So when your airways are closed, it's reversible. Once you institute proper management, those airways will open up again. The only problem with asthma is that if it is not well controlled, then these asthmatic patients can develop an irreversible component where now their lungs become permanently damaged, and you'll see that. Also, your chronic obstructive pulmonary disease, your chronic bronchitis and emphysema, they can also have reversible features depending on the initial stages of the disease when it is mild. But now, if the initiating event becomes persistent, then most of these become irreversible. So with emphysema and bronchitis, it usually results as a result of chronic injury, especially smoking. So when you smoke, there are certain chemicals that will be released into circulation, and they will cause small airway disease. And in emphysema, the inflammation that results from this leads to alveolar wall destruction, and the lungs will appear overinflated. I'll show you an image of this. In chronic bronchitis, this leads to airway inflammation, and these patients have a productive cough. Then for asthma, this leads to reversible obstruction depending on what the trigger is. And the reversible obstruction is due to bronchial hyperresponsiveness, which will be triggered by, now your triggers are your allergens. Could be dust, could be cold air, whatever it is. Some arise secondary to viral infections. Then you get bronchial hyperresponsiveness, you get bronchospasms, and the patients present with asthma. What distinguishes obstructive diseases from restrictive diseases, which you will have a lecture of on Wednesday, is using spirometry, respiratory spirometry. So there are some tests that you do to try and see how air is flowing in the lungs. So in obstructive diseases, we have a test called forced vital capacity, FVC. And in obstructive disease, this forced vital capacity can be normal or slightly decreased. And then we have another test called forced expiratory volume at 1 second. So if we force you to breathe out the air that you've taken in within 1 second. In patients who have obstructive diseases, this is usually decreased because there's something obstructing air from coming out. And when you do a ratio of your FEV1 to FVC, it's usually decreased, and I'll demonstrate this. So let's look at these tests in more detail. So FVC, or forced vital capacity, is the total volume of air that a person can forcibly exhale after taking a full inspiration. So if you take a deep breath, that total volume of air that you had inhaled and you can forcibly exhale it, we call that a forced vital capacity, and it usually reflects your lung capacity, how much air your lungs can hold. This forced vital capacity is usually reduced in restrictive lung diseases, which we said you're going to learn on Wednesday. And forced vital capacity is usually measured in liters, and a normal adult has a forced vital capacity of about 4 to 5 liters. For your forced expiratory volume in 1 second, this is the volume of air that is forcibly exhaled in the first second of the forced vital capacity maneuver. So if you're exhaling, the total volume you've exhaled is your forced vital capacity. But we also measure the volume that you've exhaled in the first second, and that is the forced expiratory volume in 1 second. And it usually reflects airflow in large and medium airways. So FEV1 is what is mostly affected in obstructive diseases. We've said FVC will be affected in restrictive diseases. It is also measured in liters, and a normal adult usually exhales about 70 to 80% of their forced vital capacity in their first second. So what is the relationship between the two? So when you measure your FEV1 and you perform a ratio, your ratio normally should be more than 0.7, or what is age-adjusted lower limit of normal. So we always say there are reference ranges. So there'll be reference ranges for specific ages, but no matter what, the normal should be greater than 0.7. So in patients who have obstructive disease, this ratio is usually low. It's usually less than 0.7. And this is because their FEV1 is usually reduced more than their forced vital capacity. In restrictive disease, this is usually normal or high, and it's because both your FEV1 and your forced vital capacity are usually reduced proportionately So there's no much difference in uh, uh, in your EV1 and FVC ratio. So let's take a clinical example in a patient who has emphysema. So a patient has emphysema and you perform spirometry. Right now you have the advantage of YouTube. You can go to YouTube and see how spirometry is performed. So you perform their forced vital capacity, you find that it is 3.8 liters, and their FEV1 is 1.9 liters. So when you will calculate their FEV1 FVC ratio, which will be 1.9 over 3.8, you find that their ratio is 0.5. So of course, we've said that in obstructive diseases, the ratio is usually less than 0.7. So in this case, this patient had a ratio of 0.5, and this confirms airway obstruction. And then you tie it in with whatever the patient is presenting with, what their x-ray is showing or CT scan, then you can tie in and say that this patient actually has an obstructive disease. So let's look at each one of these conditions one by one. We start with emphysema. And we said emphysema is diagnosed on the basis of morphology, how the lungs appear. So emphysema is usually characterized by two main things. One, you have irreversible enlargement of air spaces distal to the terminal bronchi and bronchioles. And we said that emphysema usually affects the acinus. So what is the airspace distal to the terminal bronchioles? It is the acinus, and you have irreversible enlargement. Then we have alveolar wall destruction with minimal fibrosis. So whatever the inflammatory process is taking place, it leads to alveolar wall destruction. But unlike the healing that we know, healing by fibrosis, in emphysema, the fibrosis is usually very minimal. So based on that, emphysema is usually classified according to its anatomic distribution, which part of the acini is affected. So we have four main types. So we have central acina or central lobular emphysema, meaning that the central part of the acini is what is affected. Then we have panacina or panlobular, which means that the entire acini is affected. Then we have distal acina or paraseptal emphysema, which means that the distal part of the acini is what is affected. And then we have irregular emphysema, irregular on the basis that you cannot multiple places or maybe one part of the acini is affected, and you cannot classify it as either central acina, panacina, or distal acina, where the distribution is irregular, but I'll show you an image of it. So from your anatomy, of course, you know that the trachea usually bifurcates to form the right and left bronchus, and then these bronchus will now divide until eventually you form your terminal bronchioles, which then bifurcate into your respiratory bronchioles and then to your alveoli. And this is a part. So the respiratory bronchioles plus the alveoli is what forms the acini. So when we talk about central acinas, central acina emphysema means that the middle, central, the middle. Panacina, the entire acini is affected. Distal, the distal part. Irregular means maybe you can have this part is affected, this other part is affected, but you can't really classify it into a specific pattern. It is also important to remember the structure of the lung, because when we'll be talking about the morphology, we'll see that there's those disorders that will affect a particular part of the lung, like the upper lobe or the lower lobe. So of course, you know, the right lung has 3 lobes, the left lung has 4 lobes, and each lobe has an apex, Then you have the lower lobes, and of course, there's a diaphragm below the lungs, and the different bronchioles. So we'll talk about the various parts of the lungs being affected by the obstructive diseases that we'll discuss. So let's look at each one of these types of emphysema. Let's start with central asthma. So in central asthma emphysema, you have destruction and enlargement of the central or proximal parts of the respiratory unit, and this usually spares the distal alveoli. For those who have central asthma emphysema, this will predominantly involve the upper lobes and the apices of the lungs, like I was showing you. So the upper lobes. So the lower lobes will be spared from the central asthma emphysema. So central asthma emphysema usually occurs primarily in heavy smokers, and more often than not, it is associated with chronic bronchitis. Then we have pan-asthma emphysema. So in pan-asthma emphysema, you have uniform destruction and enlargement of the acinas, where the entire respiratory acinas from the respiratory bronchiole to the alveoli will be affected with that uniform destruction and enlargement. And for pan-asthma emphysema, it usually predominates the lower basal zones, unlike the central asthma. And most of the time, your pan-asthma emphysema has a strong association with your alpha-1 antitrypsin deficiency, and especially for patients who have pure emphysema, like I had stated. So this is just an image to demonstrate for you the acini. So we start from your respiratory bronchioles that then terminates eventually to give you your alveoli. So when you have central acina, it's the central part of this acini is what is affected. Then for pan-acini, you're affecting everything from the respiratory bronchioles all the way to the alveoli. Then we have distal acina emphysema, which involves mostly the distal acinas. The proximal part of the acina is usually normal. It will typically occur near the pleura and adjacent to fibrosis, scars, or atelectasis. So you will see this type of emphysema where there's fibrosis of the lungs, or where there are scars, or where there's lung collapse. Frequently, the underlying lesion is distal acina emphysema when you have a young adult presenting with spontaneous pneumothorax. So what is pneumothorax? When someone suddenly presents with difficulty in breathing, and you find that they have air within the pleural cavity. So that's what we call a spontaneous pneumothorax. So there's no trauma. Normally, pneumothorax will see it in trauma, but in this case, there's no trauma. So it's just spontaneous. And most of the time, it will be because the patient has a distal acina emphysema. So in this condition, it usually presents with multiple contiguous and enlarged air spaces that are usually about 0.5 millimeters to 2 centimeters in diameter. And these enlargements can then progress to form cystic structures within the lungs that are called bullae. It's like you have a blister in the lung. That's basically what that means. So we said distal acina emphysema is also called paraseptal emphysema, and you can see it's affecting the alveolar ducts and alveoli, the distal part of the acini. Then we have irregular emphysema, often associated with scarring, so-called as the acina is involved irregularly. It results from healed inflammatory diseases and is the commonest type of emphysema. So this is just to show you in summary. So we said your acini is from your respiratory bronchioles all the way to your alveoli. So centri acini is when the central part of this acini is affected. Pan acini is when this entire acini is affected. Then paraseptal distal acini is when the distal part of the acinus is affected. And then irregular is there is no known distribution, just various parts of the acini are affected. So, what is the pathogenesis? How do you develop emphysema? So, emphysema usually results from imbalances between pulmonary proteases and their inhibitors. I think we went through in cell injury in your general pathology lectures where we talked about these oxidants, there being antioxidants, natural antioxidants within the body that usually counteract the activity of these oxidants. So when you have an imbalance between pulmonary proteases and the inhibitors, so where is the scale tipped? So if you have an excess of your proteases and they overwhelm your inhibitors, then you end up having more destruction of your lung parenchyma. And this will also, like I've said, be made worse by disparities in oxidants and antioxidants. And these are your reactive oxygen species, and the antioxidants are your like your enzymes or your endogenous antioxidants like your vitamin A that usually help to counteract the activity of these oxidants. So in the end, you end up having more destruction. So it involves also an interplay between genetic susceptibility and environmental triggers. That is, in this case, inhaled cigarette smokes or other noxious particles like what you'll inhale in air pollution if you're cooking with charcoal or firewood, and this will cause lung damage and inflammation. Why is this important? Because we all know smoke. Maybe you have someone in your family who is a smoker, but you've seen there are certain people who smoke until they are 100 and never have a lung issue. Yet there is someone who will smoke and then when they turn 40, they start having lung issues. And this comes because of these genetic differences between one person and the other. So there's that genetic susceptibility that causes you maybe to have more pulmonary proteases as opposed to their inhibitors, or you have more oxidants than the antioxidants, and this will play a role in increased destruction and inflammation in the lung. So we have alpha 1 antitrypsin deficiency. So those who are at a high risk of developing emphysema are, for example, patients with alpha 1 antitrypsin deficiency, and this is a hereditary disorder. So alpha 1 antitrypsin is a major protease inhibitor whose main purpose is to neutralize neutrophil elastase in the lung interstitium and to protect the lung parenchyma from elastolytic breakdown. So if not inactivated by your alpha 1 antitrypsin, your neutrophil elastase will destroy lung connective tissue, leading to emphysema. And therefore, severe alpha 1 antitrypsin deficiency usually predisposes to unopposed elastolysis with a clinical sequelae of early onset of pan-acina emphysema. So you have this neutrophil elastasis being allowed to just destroy tissue without any opposition. And now this leads to destruction of the acini, causing emphysema. The other risk factor we've said is tobacco smoking. Nicotine that is found in tobacco usually recruits and activates inflammatory cells, especially your neutrophils and your macrophages, and this usually will release proteases. And sometimes this nicotine can also inactivate your alpha-1 antitrypsin so that you do not have an inhibitor to the proteases that are being released from your neutrophils and macrophages. Also, with that combustion effect of tobacco, you have a generation of reactive oxygen species. And you also have these neutrophils that are being recruited because you're causing cell injury. And this will release your reactive oxygen species, and you'll have excess oxidants. So your reactive oxygen species are your oxidants, and they will overwhelm your antioxidants, and you end up having more lung damage. So this is just a diagrammatic representation. So you have your environmental exposures, your tobacco smoke, your biomass fuels, and others. And also, we've talked about genetic susceptibility. For example, people with transforming growth factor beta 1 polymorphisms, or those who have alpha-1 antitrypsin deficiency. So you have exposure to these noxious agents that cause cell injury in the lungs. And of course, this will trigger death by, remember, from cell injury, apoptosis, or necrosis. The damage is a noxious agent, so your body will respond by starting inflammation. Then you'll also have apoptosis of your mesenchymal cells. You'll have impaired proliferation, decreased contraction, decreased matrix synthesis because of destruction of your mesenchymal cells, and all this will lead to alveolar parenchymal destruction that leads to the development of emphysema. So loss of your alveolar elastic tissue reduces the radial traction and causes your respiratory bronchioles to collapse during expiration, and this results in functional obstruction. So you need elastic tissue for the alveoli to expand and contract. But now you've produced elastases that have now led to the elastolysis. So you have led to breakdown of elastic tissue. And therefore, this will reduce radial traction, and it will cause your respiratory bronchioles to collapse during expiration. And this, so expiration, you want to breathe the air out, but now your bronchioles have collapsed, and therefore you cannot be able to breathe that air out. And that's why we were saying in obstructive diseases, your forced expiratory volume is usually decreased because of that functional obstruction. Also, small airway inflammation causes there to be goblet cell metaplasia with mucus plugging. So within the respiratory epithelium, of course, we have goblet cells that secrete mucin. And you know the purpose of mucin or mucus is to entrap these noxious substances or infectious agents. But now when you have inflammation, you have excess growth of these goblet cells. So you have metaplasia. So you have the respiratory epithelium moving from that respiratory epithelium, that ciliated pseudostratified epithelium, to now having excess goblet cells. And when you have excess goblet cells, you have excess mucus secretion that will lead to mucus plugging. As well as you'll have bronchiolar wall thickening due to fibrosis and smooth muscle hyperplasia, and this will therefore augment the airway obstruction. So you have cell death. Of course, you will heal with a bit of fibrosis, but remember in emphysema, the fibrosis is not as marked as you would expect to with the extent of injury. So how do these patients present? These patients will present with dyspnea, and dyspnea is where you have difficulty breathing. And this will be seen when a third of your pulmonary parenchyma has been lost. These patients are going to have difficulty in breathing. Because of that airway collapse, they're going to present with wheezing. They're also going to present with cough. Of course, there's irritation by the noxious agents, the inflammation. So there's going to be cough. They also do develop weight loss because that carbon dioxide oxygen exchange is compromised. So most of these patients end up retaining eventually a lot of carbon dioxide, and this is detrimental to the metabolic activities of the body, and they end up having weight loss. Then also, when you're spending most of your time trying to breathe, then also feeding becomes compromised, and these patients have weight loss. Then they have what is called a barrel chest with prolonged expiration, because they're using more energy to be able to expel the carbon dioxide as opposed to a normal patient. So patients who have pure emphysema, like for example, those who have Panacea emphysema in alpha-1 antitrypsin deficiency, they usually will overventilate to compensate for the loss of parenchyma, and therefore they're usually called pink puffers. So they're just breathing in and breathing out, so they're just overventilating. So we call them pink puffers. So what is a barrel chest? I'm just trying to demonstrate the normal chest. So a barrel chest, you can see this curvature at the back. This is an actual patient. So the sternum sort of goes inside, and at the back you have sort of a hump. So this is a barrel chest that you usually see in patients who have emphysema. They also develop pulmonary hypertension. I think you'll have a lecture on pulmonary hypertension. And the pulmonary hypertension is due to hypoxia that is induced by pulmonary vascular spasms and loss of pulmonary capillary surface due to alveolar destruction. Of course, your pulmonary circulation goes all the way to the alveoli. That's where oxygen and carbon dioxide exchange occurs. But now your alveoli is destroyed, and with that, it will lead to loss of your pulmonary capillary surface. Then how does your body respond? There's resistance to blood flow. So your body will try and increase the pressures to increase that blood flow, and that's how you develop pulmonary hypertension. In 20 to 30% of the patients, because of severe pulmonary hypertension, they end up developing right-sided congestive heart failure, what we call copulmonale, meaning that the heart failure is as a result of a lung abnormality. So heart failure due to lung abnormalities, we call that copulmonale, and this is usually a poor prognostic indicator. In severe emphysema, patients might die, and death is due to the respiratory acidosis, the right-sided heart failure, or they can develop a massive pneumothorax. Of course, when you have air in the pleural cavity, that expansion or that space for your lungs to expand and contract is compromised, and this can lead to death. How do these lungs appear? Of course, you have this irreversible enlargement of your alveoli. That's one of the characteristics we have spoken about in emphysema. And as a result, your lungs become voluminous. They become big, and they overlap the heart, particularly in Panacea emphysema. What does this mean? You've all done anatomy. So these lungs are so big that you will not be able to see the heart. That's why we mean that it will overlap the heart. Microscopically, Your alveolar spaces are usually enlarged and they will be separated by a thin septa. Your septal capillaries are usually compressed and bloodless because of that enlargement. And you can also have, because your alveolar spaces are enlarged, you can have alveolar wall rupture, and this can produce very large air spaces, what we now call the blebs or the bulla. It's like you have like a blister. So you can see in this lung, so these are your bullae and your blebs. It's like you have blisters on the heart. Then grossly, you can see you have these spaces, and it appears like you have cysts within the lungs. Yeah, this is likely a patient with cystic. So this is a histological image of the lung, and you can see this alveoli are fragmented. We've talked about alveolar rupture, and then you can see this alveoli a septal membrane, and this is what you see in emphysema, this enlargement of your alveoli. They are dilated, and you can see places of rupture. So in patients who have emphysema, the goal of therapy is usually to relieve the symptoms, to prevent disease progression, to improve exercise tolerance and health status, and also to prevent and treat complications and exacerbation. So you want to prevent things like pulmonary hypertension, because now this will lead to right-sided heart failure, and of course we've seen that will cause death. And of course now you want to reduce mortality that will arise from the complications. I think that's with emphysema. Any question? So emphysema mainly associated with alpha-1 antitrypsin deficiency, that now will most likely give you your pan-acina emphysema, and also cigarette smoking, and also air pollution, as seen in low and middle income countries like Kenya. So let's look at chronic bronchitis. And we said that emphysema is defined based on morphology, while chronic bronchitis is based on the clinical symptoms. So therefore, chronic bronchitis is defined as persistent cough with sputum production for at least 3 months, in at least 2 consecutive years, but in the absence of any other identifiable cause. So there's someone who's asking, I didn't understand the question. How long do you expect to see emphysema clinical features for smokers? Do you mean how long do the symptoms take to develop? Or I don't understand the question. Like I said, it's an interplay between genetic susceptibility and also how much someone smokes. So there's no clear-cut duration that if you smoke for 20 years, you'll get emphysema. There are those who will even smoke for 5 years and get emphysema. There are those who will smoke for 30 years to get emphysema. So it all depends on your genetic susceptibility and also how much of the cigarettes you're consuming. I mean, if someone takes one cigarette per day and another one takes a packet or two per day, then of course you expect the one who's smoking more to develop the emphysema faster than the one who's taking fewer cigarettes. And then also, what is your genetic susceptibility? Are you able to form more antioxidants? Are you able to form more inhibitors of your proteases? So yeah, but there's no clear-cut duration. Is that clear? So yeah, now let's look at chronic bronchitis. So like I've said, it's defined based on clinical features, and you have persistent cough with sputum production for at least 3 months in at least 2 consecutive years. So what does this mean? So between October and December in 2024, the patient had cough for 3 months. Then in 2025, June, July, August, they had cough. So, and it is a productive cough. And there is no identifiable cause. That means you cannot pinpoint. You can't say, oh, yeah, he coughed because he had pneumonia, and you actually did a lab and you confirm that the patient probably had pneumonia. That's why they coughed, or they had TB or whatever. So there's no identifiable cause. The patient is just coughing for at least 3 months in at least 2 consecutive years. At least, meaning that the cough can be longer. Maybe they coughed for 4 to 5 months, but in 2 consecutive years in the absence of any other identifiable cause. So the alveolar epithelium is usually both the target and the initiator of inflammation in chronic bronchitis. The target, because when you smoke, those noxious substances will settle in the alveolar epithelium, and as such, that's where the inflammation is going to start. So chronic bronchitis is common among cigarette smokers and also urban dwellers like ourselves. And this is due to exposure to air pollutants, like there's sulfur and nitrogen dioxide, which is usually produced from combustion. So the distinctive feature of chronic bronchitis is the hypersecretion of mucus beginning in the large airways. So they present with a productive cough at least 3 months in at least 2 consecutive years. So how do you develop chronic bronchitis? So it develops because of chronic irritation of the airways by inhaled substances, especially tobacco smoke. And this is the dominant pathogenic mechanism. So when you have chronic irritation, this leads to what? It leads to inflammation, because always, that's why we always do general pathology, cell injury. Yeah. So this tobacco smoke is causing cell injury that leads to death by necrosis, that leads to inflammation. Not only that, you can have inflammation without necrosis first if that irritation is persistent. So this leads to inflammation. And of course, with inflammation, you have infiltration of the inflammatory cells, your macrophages, your neutrophils, and your lymphocytes. Then what does your body do? It tries to respond by producing more mucus so that it can be able, remember the purpose of mucus in the airways is to trap those substances, those inhaled substances. So you'll end up having mucus gland hypertrophy in the trachea and bronchi with mucus hypersecretion. And this is usually stimulated by your neutrophil proteases that have come as a result of inflammation. Okay. So when you have that, you also have goblet cell metaplasia in the bronchiolar epithelium. So you're moving from your respiratory epithelium to a goblet cell-like epithelium, which contributes to mucus production and small airway obstruction. So you're producing more mucus that it ends up clogging your airway. You can also have bronchiolitis with wall thickening due to fibrosis and smooth muscle hyperplasia. So bronchiolitis is the small airways, your terminal bronchioles. So of course, with inflammation, you'll end up healing, and you heal with fibrosis, and you also have smooth muscle hyperplasia. And then in these patients, they also develop secondary infections that will exacerbate the smoking-initiated injury. So your airway obstruction in chronic bronchitis usually is due to small airway disease induced by mucus plugging. As you can see, you have mucus gland hypertrophy and you have goblet cell metaplasia. So this will lead to mucus plugging of your bronchiolar lumen. Also with that inflammation, what is one of the side effects of or the features of inflammation is you have edema that will exacerbate that blockage. And of course, as you're healing with fibrosis, then also this exacerbates the blockage of your airways. And then also we said that chronic bronchitis usually coexists with emphysema. So you also have that alveolar destruction that you see in emphysema, and this contributes to that airway obstruction, like we've discussed in emphysema. So how do the lungs appear in patients who have chronic bronchitis? The lungs are usually hyperemic and they have edema. So the mucous membranes will be hyperemic. So they appear red and they'll be edematous with enlargement of mucus secreting glands, especially, and this will be seen especially in your larger airways. So in your large airways, the main bronchi, you're going to see your hyperemia and edema and enlargement of mucus secreting glands. In the smaller bronchi, you're going to see mucinous secretions that fill the airways. And then microscopically, of course, you are going to appreciate that mucus gland hyperplasia and also that goblet cell metaplasia. You're also going to see bronchiolar inflammation and fibrosis. Of course, with persistent smoking, the bronchial epithelium also undergoes squamous metaplasia. And that metaplasia can become dysplastic, and hence why in smokers they get squamous cell carcinoma. In severe cases, there may be complete obliteration of the lumen as a consequence of the fibrosis that results, and this we call bronchiolitis obliterans, that the fibrosis has completely closed up the lumen. So this is just histologic representation of the same. So in your image, the upper image labeled A, so this is a section of your bronchial wall, and what you can see in the lumen, so this is the lumen, I hope you can see my cursor, you're seeing this amorphous whitish material, so this is your mucus. And then what you can note in this respiratory epithelium, so this has respiratory epithelium, but you have these clear cells, and these are your goblet cell. So you have hyperplasia of your goblet cell, and then the basement membrane. I hope you can see my cursor. It appears more thicker than usual. So you have thickening of the basement membrane, and then you have these black dots, and these are your inflammatory cells. So you have scattered mononuclear inflammatory cells. These are your lymphocytes and your macrophages. On the image labeled B, it's still a histologic image of your bronchial wall. Um, uh, bronch- um Bronchial wall. So there's the smallest, the bronchial, and the bronchial. So this is the larger airways. And of course, in the larger airways, you're going to see, you can see the difference between this epithelium. So this is the respiratory epithelium, of course, with goblet cell hyperplasia. But you can see here, there is squamous cell metaplasia. So this epithelium has been replaced by squamous cell, and then you also have these mucus glands that are usually in the subepithelial space, and you can see that there is hyperplasia of these mucus glands. So how do these patients present? Of course, they present with cough. Because of that mucus gland hyperplasia and goblet cell hyperplasia, they have sputum production. They also have dyspnea on exertion. And dyspnea on exertion means that you have difficulty in breathing when you're performing sort of a strenuous exercise. I'll give you an example. Maybe you climb 3 flights of stairs without having to you don't have any difficulties in breathing. And then you notice all of a sudden that when you go up 3 flights of stairs, you are like out of breath. So that's dyspnea on exertion. So in classic cases, patients with chronic bronchitis are usually hypoxic, have low oxygen, they retain more carbon dioxide, and therefore we call that hypercapnia. And then cyanotic, because of that having increased deoxygenated blood, they have bluing of their membrane, so they appear cyanotic, and therefore we call them blue blotters. In emphysema, we call them pink puffers because they overventilate. In chronic bronchitis, we call them blue blotters. In long-standing disease, this will often progress to cor pulmonale. So you also get cor pulmonale, and they can also die. And this chronic bronchitis, you have exacerbation by infections, and this can eventually lead to death. I think I was trying to show you an image of, you can see how blue the area around the mouth is. You can see bluing on their fingertips. That's a patient who is cyanotic. Of course, it's not only chronic bronchitis that causes you to be cyanotic, but of course, in your clinical scenario, you will have done your due diligence and come up with a diagnosis of chronic bronchitis for you to have this. This can also be caused by other things, but this is what you expect in a patient who has chronic bronchitis. Any question on chronic bronchitis? Let's move to asthma. This is a condition that we are more conversant with, and asthma is a chronic relapsing inflammatory disorder that is characterized by paroxysmal reversible bronchospasms due to smooth muscle hyperactivity and increased mucus production. The relapsing and paroxysmal means that this patient does not have this condition throughout. It's something that comes and goes. And those who suffer from asthma or you have a family member with asthma, I'm sure you know that that is true. So they don't have wheezing all the time. There's a trigger that leads to the wheezing. So that's what we're talking about, paroxysmal reversible bronchospasms. That when they're put on treatment, like they take their inhalers, the bronchospasm abates and they go back to normal. So globally, asthma affects about 300 million people. In Kenya, it is postulated that 10% of the population is affected by asthma, which means for every 10 people, at least there's one person who has asthma. And asthma is the most common chronic disease among children. And what has been found is that the incidence has increased over the years. And this is postulated due to what is called the hygiene hypothesis. If you see the conditions in which we grew up in, and now they're very different. People are more clean. You try to prevent your child from going into dirty environments. And what that does is it reduces exposure to infectious organisms in early childhood. So, this exposure to many antigens is what builds immunity. But if you're not exposed to these antigens, then you'll have defects in immune tolerance and you'll eventually have hyperactivity to immune stimuli later on in life. So it's important to expose children to as many infectious agents, as many stimuli, antigens as possible to try and build up their immune tolerance. Asthma is usually categorized into two major forms. So we have atopic or allergic asthma, and then we have non-atopic asthma. And in this all types of asthmas, you'll have inflammatory cells involved, and you'll mainly see your eosinophils, your mast cells, and this will mainly be seen in your atopic asthma, but you'll also see macrophages, lymphocytes, neutrophils, and epithelial cells. I think in the semester on general pathology, we went through hypersensitivity reactions and we discussed type 1 hypersensitivity reaction. Minute. Sorry for that. So, like I was saying, in the last semester with us, we discussed hypersensitivity reactions, and we went through type 1 hypersensitivity reaction, which is the reaction that governs atopic asthma. So after this, I urge that we go back and read about the sequence of events in a type 1 hypersensitivity reaction, and it will help us understand this atopic asthma better. So atopic asthma will be the most common of the two types. And of course, I've said it is caused by a type 1 mediated hypersensitivity reaction. Type 1 or IgE mediated reaction that will be triggered by environmental antigens. This can be pollen, certain foods, viral infections, cold air, stress, exercise, airborne irritants, animal dander, like there's so many things, yeah. And in patients who have atopic asthma, they usually have a family history of atopy. So there's usually that genetic susceptibility that will govern development of atopic asthma. For the non-atopic asthma, this is mainly triggered by respiratory tract infections. It can also be triggered by chemical irritants, and we'll look at occupational asthma, or it can be triggered by drugs, drug-induced asthma. And in these patients, there's usually no family history. So there's no genetic susceptibility that can be found that will cause this person to develop asthma. And in these patients, they usually have airway hyperirritability that is attributed to viral or chemical induced inflammation that reduces the threshold of vasostimulation by other minor irritants, and therefore their body hyperreacts to those irritants. So these are just types of your non-atopic asthma, your drug-induced asthma that can be induced by, for example, your NSAIDs like your aspirin. And it's because these agents inhibit cyclooxygenase without affecting lipooxygenase's activity. And therefore, because they inhibit your cyclooxygenase, and they do not affect your lipooxygenase activity, they tip the balance of arachidonic acid metabolism towards bronchoconstrictor synthesis of leukotrienes. And leukotrienes are major molecules that play a role in that bronchial hyperresponsiveness that leads to bronchospasms. For occupational asthma, because of the chemicals, it's due to when you have repeated exposure to chemicals that are coming from fumes, in organic, chemical and organic dusts, like those who work in wood factories, factories that whatever, like work with cotton or platinum. So these are some of the chemicals that are going to trigger this non-atopic asthma. So what is the pathogenesis? So asthma is usually associated with genetic predisposition. This is for your atopic asthma. So the strongest genetic association has been made with certain human leukocyte antigen, your HLA alleles, and also polymorphisms in your interleukin 13 and CD14, which is the monocyte receptor for endotoxins. Therefore, they can be easily triggered by infections. Also, alterations in your ADAM33, which is a matrix metalloproteinase that influences smooth muscle and fibroblast proliferation. Also, mutations in your beta-2 adrenergic receptor, which influences your airway reactivity, and also the interleukin-4 receptors. And you'll see, we'll talk about interleukin 13 and interleukin 4, which are important in your type 1 hypersensitivity reactions. And in atopic asthma, your T cell differentiation is usually skewed to overproduce your T helper 2 cells, and this leads to an IgE and eosinophil dominated immune response. please go back and read your type 1 hypersensitivity reaction. So in atopic asthma, of course, you have exposure to your pollen or whatever your trigger is. And then, of course, this antigen will be taken up by your dendritic cell, and it will be presented to your T cell receptor, which will produce cytokines that trigger a T helper 2 proliferation. So you'll activate your T helper 2 cells, and your T helper 2 cells will then secrete interleukin 4. Interleukin 4 causes your B cells to class switch from IgM to IgE. Your T helper 2 cells also produce interleukin 5, which recruits your eosinophils. And then, of course, we know that this IgE then goes and binds to your mast cells, so that now on your second exposure, then you'll have degranulation of these mast cells, leading now to your hyper responsiveness. And of course, we know that a type 1 hypersensitivity reaction has an immediate phase that occurs within minutes due to that degranulation of your mast cells and production of things like your histamine. And then also we have the late phase because of the signal transductions that lead now to triggering of production of your leukotrienes and your prostaglandins that will now affect the late phase reaction. So please go and read again on your type 1 hypersensitivity reaction. So for your acute phase, that antigen binding to IgE-coated mast cells cause primarily production of your acute phase mediators, which will lead to bronchospasms, and this will lead to edema. They will also lead to increased mucus secretion and leukocyte recruitment. In your late phase, this will be mediated by your recruited leukocytes from the acute phase. Also your eosinophils, your neutrophils, and your monocytes. And your late phase is characterized by persistent bronchospasms and edema. And you also have leukocytic infiltration and epithelial damage and loss. Then what happens is with repeated asthma or repeated bouts, they'll cause your airway to remodel with bronchial smooth muscle and mucus gland hyperplasia and hypertrophy. They will also cause increased vascularity, and you'll have increased deposition of your subepithelial collagen. And now this leads to your chronic effects of asthma. So how do the lungs and airways look? So in asthma, the lungs are usually overinflated with patchy atelectasis and mucus plugging of your airways. Atelectasis is collapse, so you'll have patchy collapse of certain parts of the lungs. Microscopically, the lungs usually exhibit edema. You're going to have bronchiolar inflammatory infiltrates with numerous eosinophils. You'll also have subepithelial fibrosis, and you'll have bronchial smooth muscle and mucus gland hypertrophy. Then characteristically, these mucus plugs usually appear walling. Please Google what walling is, but I have an image of it. And they have what are called crystalloid eosinophil granule debris, what we call the charcot-laden crystals that you're going to see in the airways. I think I have an image of that. So initially, you have this. This is just a histologic image to demonstrate the mucus plug that you will see in the airway. So this is the luminal side. They have basement membrane thickening. Of course, since this is a type 1 hypersensitivity reaction, they have an eosinophil-rich inflammation and edema. Then we've talked about smooth muscle hypertrophy that occurs in response. And you also have submucosal gland hypertrophy, these mucus glands that are responsible for the production of this mucus that you see in the lumen. So these are what we are calling your walled mucus plugs, the Kuchman spirals. I hope I'm pronouncing that um, correctly. So these are your Kuchman spirals, you can see. So your mucus plugs. And then you have your Charcot-Leydig crystals. So this is eosinophilic. I hope you can see my cursor. So this is what you see characteristically under a microscope in patients who have asthma. How do patients present? Um, of course, we say a patient is having an asthmatic attack. So the classic attack usually lasts up to several hours, and the symptoms include chest tightness, they have wheezing, they have difficulty in breathing, dyspnea, and some will present with cough. In some patients, this can occur in severe episodes that don't respond to therapy, and that we call status asthmaticus. And these are patients who have to be admitted. Some even have to be put under medically induced comas because of this. So these acute symptoms usually persist for days to weeks, and significant airway obstruction can cause, if it is severe, it can cause cyanosis and can even cause death. I'm sure we've heard of people who've died during an asthmatic attack. So when you institute treatment in these patients, you want to um, avoid the late phase reaction that prolongs this asthmatic attack. So you want to give them anti-inflammatory drugs. You also want to give them glucocorticoids, which also act as anti-inflammatory drugs. And you also want to give them bronchodilators, like your beta adrenergic drugs and your leukotrienes inhibitors, so that they can reduce that bronchial airway hyperresponsiveness, and they go back to breathing normally. So please go back to the general pathology lecture, go through again your type 1 hypersensitivity reaction. We can ask it again in the context of pathogenesis of asthma. Let's look at the last chronic obstructive disease, and that is bronchiectasis. And bronchiectasis just means permanent abnormal dilatation of the bronchi and bronchioles that is caused by chronic necrotizing infections associated with airway obstruction. So the event can either be it was an airway obstruction that led to necrotizing infection, or you can have an infection that leads to obstruction. So these infections lead to destruction of smooth muscle cells and smooth muscles, and they also lead to destruction of the supporting elastic tissue. And how these patients present is that they present with cough, and they have expectoration of copious amounts of purulent sputum. Copious means that whatever they're coughing out is a lot. They produce a lot of sputum. Purulent means it looks like pus. Yeah. And we'll see why. So what predisposes you to bronchiectasis? We've talked about airway obstruction, and this can be caused by tumors, Airway obstruction can also be caused by foreign bodies. We've had people who inhale coins like children, seeds, or whatever it is. All these are foreign bodies that will lead to obstruction. You can also have airway obstruction by impacted mucus that we were talking about in patients who have cystic fibrosis, or in patients who have severe chronic bronchitis. So they are producing a lot of mucus that blocks the airways. Or airway obstruction can be because of post-infective scarring causing luminal narrowing. Like, for example, if you had an infection with tuberculosis and you ended up having scar tissue formation, and this scar tissue forming in airways leading to luminal narrowing. Another thing is predisposing condition can be your congenital or hereditary conditions. Commonest is what we call cystic fibrosis. Sorry, I think when I was talking about alpha-1 antitrypsin, I was talking about cystic fibrosis. No, those are two different things. Alpha-1 antitrypsin deficiency, that's a different genetic disorder that predisposes you to emphysema. Then we have cystic fibrosis, which is another genetic abnormality. And in cystic fibrosis, they usually have, you can go and read about cystic fibrosis in your own time. And in these patients, they have thick, viscous secretions in the airway that lead to obstruction. And when the airway is obstructed, it creates a breeding ground for infection. Then another congenital disorder is your primary ciliary dyskinesia, or what we call Cartagena syndrome. So in these patients, they have ciliary dysfunction. Of course, you know, the respiratory epithelium has cilia that helps in taking away that entrapped substances. They are taken away by that cilia movement. So if you have cilia dysfunction, you end up having poor mucociliary clearance. You have persistence of substances that can cause infection, or because you have poor mucociliary clearance, you have accumulation of substances that can eventually lead to obstruction. Then also immunodeficiency states. Please go back to your semester with us when we took you through general pathology and we talked about immunodeficiency, but particularly in immunodeficiencies in your adaptive immunity that affects your B cells, and therefore you're not able to produce immunoglobulins, then that means that you are susceptible to infections, especially infections that affect your pulmonary system. Then the third predisposing condition is your necrotizing or suppurative infection. So if you get infections by Staphylococcus aureus or Klebsiella, then this will easily lead to damage, which we were talking about, that leads to obstruction. So post-infective scarring. So you have these necrotizing infections that lead to extensive destruction of your airways, and you'll end up having obstruction that leads to development of bronchiectasis. So how do you develop bronchiectasis? So what is the pathogenesis? There are usually two intertwined processes that contribute to bronchiectasis, that you'll have obstruction and chronic infection, and one can precede the other. So when obstruction is the initiating event, you have impaired clearing of secretions, and you have persistence of bacteria in the airway, and then you have infections. And you'll have, of course, where there's infection, there's inflammation, and where there's inflammation, you have damage to your bronchial wall, leading to irreversible dilatation. Where you have infection as the initiating event, infection will lead to tissue destruction, which will further exacerbate obstruction. Of course, where you have obstruction, you have more infection, and this is a vicious cycle. And therefore, where you have obstruction plus infection, you end up having bronchiectasis. So, grossly and microscopically, how does bronchiectasis appear? What is the morphology? So, grossly, you're going to see dilated bronchi extending to the pleural surface. The airways are usually markedly dilated, sometimes 4 times the normal size. And these airways will be filled with mucopurulent secretions, because one of the clinical symptoms we've talked about is that secretion of copious amounts of purulent sputum. This bronchiectasis is usually more severe in the lower lobes. It will present most of the time bilaterally, so the right and the left lobe will be affected, and it will be more severe in airways that are vertical in shape. Because of that, when an airway is vertical, it means clearance of secretions from the airway is difficult. Microscopically, you're going to see acute and chronic inflammation. You will see destruction of your airway walls, particularly your elastic tissue and your smooth muscle are going to be destroyed. And because of the extensive damage, you will have replacement of this by fibrosis. And then in necrotizing infections, of course, you're going to see ulceration of the mucosa. And this is usually characteristic of bronchiectasis. So this is a patient with this, I think this is a cystic fibrosis patient, but you can see this airway, they have this pus-like material, this purulent material, and you have dilatation of these airways. If you look at the gross feature of a lung, this is not the same. I wish I'd put a picture of a normal lung for comparison, but you can see the airways are dilated, and then you can see this purulent material within the airway. I hope my cursor is, you can see my cursor. What are the clinical features? So we've talked about the patients having a chronic productive cough, and they produce copious, purulent, and foul-smelling sputum. These are patients who are susceptible to recurrent respiratory infections. They can also develop hemoptysis due to erosion of bronchial arteries, especially where you have necrotizing infections. And these patients also present with dyspnea, orthopnea, where they have difficulty breathing when they lie down, they have hypoxemia, hypercapnia, and they might also develop pulmonary hypertension in advanced disease. So what are the complications? They can develop respiratory failure. Of course, if you're destroying the architecture of the lung, you're going to lead to respiratory failure. Because of the pulmonary hypertension, they will develop copulmonale. And then because of the persistent infections and you're producing immunoglobulins, you have laying down of amyloid. So they get secondary amyloidosis, especially the AA type. And then these infections can embolize to other areas. And if they go to the brain, you're going to get a brain abscess. I think that's my last slide. So this is just a summary of the 4 types of obstructive lung diseases. For your chronic bronchitis, the main site is your bronchus. And of course, we talked about mucus gland hypertrophy and hyperplasia with hypersecretion of mucus. Smoking and air pollutants are the main triggers, and patients present with cough and sputum production, so they have a productive cough. For bronchiectasis, also the bronchus, you have airway dilatation, permanent dilatation, and scarring. You have cause where you have obstruction and persistent infections, and of course they'll have cough with a purulent sputum. When they have an infection, of course they're going to have fever. Then we have asthma. Also the bronchus, you have smooth muscle hypertrophy and hyperplasia, excessive mucus production, you can have inflammation, and the etiology can be immunologic, where you have a type 1 hypersensitivity reaction, or for the non-atopic, where we said it can be drug-induced, or it can be chemical irritant-induced, or can be secondary to certain viral infections. And of course, they present with wheezing, cough, and dyspnea. Then for emphysema, mainly the acini, and it will present with airspace enlargement, with alveolar wall destruction. Main culprit, tobacco smoke, but also alpha 1 antitrypsin deficiency. And these patients are going to have dyspnea. For small airway disease, bronchiolitis, we talked about chronic bronchitis, also presenting with bronchiolitis. And you're going to have inflammatory scarring and partial obliteration of your bronchioles, of course, triggered by tobacco smoke and air pollutants. And these patients will present with cough and dyspnea. Any question? Any question? Okay, if there's no question, I'll assume that this is well understood. Enjoy the rest of your day.